Well, good afternoon, everybody, and welcome to our inaugural virtual ground rounds. And we are really delighted to welcome Dr. Carol Benson from Harvard School of Medicine to be our first speaker at our first ever virtual grand rounds. And just to remind all the Yale attendees to receive CME credit, you need to text the activity code 22952 to the following phone number, 203-442-9435. You can do that anytime now and for up to 15 minutes after the presentation in order to get CME credit. But as I said, we're delighted to have Dr. Benson here with us today. She is an ultrasonographer extraordinaire who has been a leader in the field, really all aspects of ultrasound, for as long as I can remember, and has been a longtime director and chief of the Division of Ultrasound at the Brigham Hospital at Partners in Boston. She's also been a co-director of high-risk obstetrical ultrasound, the radiology director of the non-invasive vascular lab, and she has sent me her CV. And I started reading it last week. I still haven't gotten through it all, Carol, but to just summarize some highlights, she's had major leadership positions in all of the both national and international ultrasound societies, but particularly at RSNA, where she served as the refresher course director for the ultrasound courses for 6 years, president of the SRU, involved with the program committee at the AIUM, and too many other committees and achievements to enumerate. In terms of her scholarship, my goodness, Carol, 212 papers, 96 chapters and reviews, and if that weren't enough, 12 books, and always on the cutting edge. I remember once seeing her on TV demonstrating how to do intervention in utero and fetuses. Just amazing work that she's been, and she's always been at the leading edge of the curve, and really one of the great proponents of ultrasound, always pushing the envelope. And so I'm thrilled that she's here today to talk to us about 3D and 4D ultrasound. So Carol, thank you very much for coming.
Thank you. I'm honored to be the first to present you in a grand rounds on virtual, and hopefully all the electronics and everything will go well. So I'm going to talk about 3D and 3D ultrasound and its uses in obstetrics and gynecology, and part of this will be a review of some of the pathologies in GYN and also in the fetus to help review for those of you who are studying for your boards. So 3D ultrasound is basically volume imaging like other forms, other modalities. We in ultrasound acquire a volume set of data, and that data, a single volume, is a 3D. But we have also the benefit of real-time ultrasound, which means that we can acquire a 3D one after the other so that we can actually do real-time volume imaging and watch how things change in 3D over time. We manipulate the data that we get in a 3D volume like we do with other modalities, reconstructing in various planes, using special processing to look at different kinds of structures like fluid structures and vascular structures. So here is a transvaginal ultrasound of a uterus, and you can see we can look at orthogonal planes so that we can get a transverse plane of the uterus, a sagittal plane of the uterus, and then a coronal plane of the uterus showing the entire endometrium. And we can get tomographic slices. This is a 3D volume through a fetal brain, and the slices are at the level of all the things we would take on a second trimester scan, from the posterior fossa and the nuchal fold up to the level of the thalami and the biparietal diameter, and up higher where we see the cavum, septum pellucidum, and the lateral ventricles. So 3D volume is here on the right on this little 9-week embryo or fetus. And the 4D is when we watch that in motion, and you can see the little arms and legs already moving at this young gestational age. And then this is the inversion mode, where we can take a fluid structure and see what its shape is. This is a large bladder in a fetus with posterior urethral valves, and we've collected it now and reformatted it so you can see the dilated bladder and the dilated posterior urethra. In gynecology, 3D ultrasound has become particularly helpful because we can see the uterus in the coronal plane, whereas on normal 2D imaging, we can only get sagittal and transverse planes. And this provides the benefit of viewing the entire uterus in the coronal plane and the endometrium. 3D can also decrease scanning time because you can store the volume and then take the vaginal probe out and send the patient and manipulate the data after the patient has left. So that will at the same time decrease patient discomfort. So these are the kinds of scans we get. We actually do a 3D of every uterus and endometrium that we take for any GYN scan, because it is so important to us to get this coronal plane. As we can see, we've got the coronal reconstruction showing the outer contour of the uterus, and then the normal contour and shape of the endometrial cavity in 2 different patients. Here again is the outer contour and the normal triangular shape of the endometrial cavity. So where is it particularly helpful? Well, it's particularly helpful to assess duplication anomalies, map fibroids, assess adenomyosis, and even to look at some cervical lesions, as well as some other endometrial abnormalities, such as to see if fibroids are submucosal, to look for polyps inside the endometrium, and to assess the implantation site of pregnancies. Duplication anomalies of the uterus are associated with infertility. Women with duplication anomalies have a higher rate of recurrent miscarriage, of miscarriage as well as recurrent miscarriage, a higher rate of preterm birth. These anomalies can be corrected surgically in some cases, and in those cases, the outcome does improve and the chance of successful fertility improves. You've all seen this chart multiple times, so you will know what these represent. The top are the normal uteruses, which are normal or may have a slightly arcuate shape. We have this septate or subseptate uteruses, where the outer contour of the uterus is normal, but a septum indents into the cavity. And we have the different types of horns or developments, where we have a unicornuate, only one side formed, a bicornuate where there's a split in the two, an incomplete fusion of the 2 horns. And here's another one that's more complete. And we can have complete duplication of the 2 horns of the uterus and the cervix and the septum all the way through, and that's didelphys. Now, if you look at ways to analyze duplication anomalies, we have 2D ultrasound, which does tell us when the endometrium is split, but makes it hard to figure out what kind of anomaly it is. We have 3D ultrasound, we have hysterosalpingography, and we have MRI. And if you compare these 4 modalities, you'll find that 3D ultrasound is equivalent to MRI in accuracy and extent of the malformation. And both 3D ultrasound and MRI are better than the 2D ultrasound or hysterosalpingography. So here we have a 2D sweep through a uterus. We can see there's divergence and then convergence of the endometrial cavities, but we don't know if this is bicornuate or septate or subseptate until we do the 3D reconstructive imaging. On the left, we have the MRI view showing a subseptate uterus, and on the right, we have the 3D ultrasound. You can see that the uterine contour is smooth across the top, but indented by a septum that protrudes into the cavity. We can assess the depth of the septum of a uterus when it's subseptate. And the way this is done is, as we've done in this place, here we see a clearly septate uterus with marked division of the 2 sides of the endometrial cavity. We draw a line through the top of the 2 endometrial the two portions and a line down the middle to the bottom of the septum, and the length of that line tells us how deep the septum is. So this patient has a subseptate uterus with quite a deep septum. She went to the operating room, and under ultrasound guidance, the septum was resected. And now you can see she has almost a completely normal shape to her uterine cavity. Excuse me. Well, here's another one. We have a split cavity. We'll take a closer look at it. And here we see this is an entire or complete septate uterus. We've reconstructed it in all three planes and then made our 4D or 3D ultrasound where we can see that the outer uterine contour is smooth, but the septum runs all the way through, in fact, even through the cervix. This is another patient with comparing the ultrasound to the MRI. On the ultrasound, again, we see a complete septum running, splitting the two sides of the endometrial cavity and running through the cervix, similar to what we see on the MRI. It's important to distinguish between a bicornuate and a subseptate uterus because subseptate uteruses have a higher rate of miscarriage and also are pretty easy to repair. In a bicornuate uterus, you have splaying of the upper portion of the uterus with indentation of the myometrium, not just the endometrium, whereas with a subseptate uterus, the outer contour of the uterus is usually pretty smooth with just a septum coming down the middle. Uterine didelphys are uncommon. It's when they're two separate uterine horns, and they're very difficult to image because the two horns diverge so much, as we can see here in this 3D reconstruction. From this patient, we were able to get each side in separate 3D reconstructions, but not put the whole thing together because our sweep wasn't wide enough for us to see it. This is an uncommon form of uterine duplication anomaly. Unicornuate uteruses turn out to be more common than we had thought, and that's because we are now discovering them because we routinely do 3D ultrasound on our patients, and we're discovering uteruses that look like this. They have a normal size, appearing to be normal myometrium, but the endometrium and the cavity is shaped in a pointed configuration, not triangular, because it's only a single horn and the other horn didn't develop. So we're finding more of these, and the women with unicornuate uteruses are at risk for preterm delivery because their uteruses are slightly smaller than a normal uterus. In addition, with a unicornuate uterus, there may be a rudimentary horn either attached to the uterus or close by that can cause problems. These rudimentary horns do not have full myometrial thickness. They may or may not have an endometrial cavity, and they can, unfortunately, sometimes harbor pregnancies that cannot make it to viability. This patient has a unicornuate uterus, or at least that's what initially was thought, but there was this bulging out to the side, and that proved to be a rudimentary horn. When pregnancies in a rudimentary horn, they typically rupture. On ultrasound, they appear as well-circumscribed pregnancies, and they appear to be outside the uterus. So they look a lot like abdominal ectopic pregnancies. So here's a patient who was having a workup for infertility. Her uterus appeared to be normal, but we found that she had a mass between her right ovary and her uterus. And this mass, when we looked very closely, appeared to be pretty closely applied to the uterus and appeared to come off and appeared to be a rudimentary horn. And we thought that it was because it was a little bit of endometrium. She had had a hysterosalpingogram, which reported a unicornuate uterus. She'd had an MRI, which reported a structure connected to the uterus, possibly a fibroid, but we suggested it might be a rudimentary horn. She underwent infertility treatments and did get pregnant, and unfortunately, her pregnancy ended up in the rudimentary horn of her unicornuate uterus. This is like an ectopic pregnancy. It cannot make it to viability, unfortunately. And so she did have surgery, and at the time they took this out so that this couldn't happen again for her next pregnancy. Now, adenomyosis is when endometrial glands embed themselves into the myometrium and then respond to the hormones that travel through the body. Patients with adenomyosis have signs and symptoms such as dysmenorrhea, abnormal bleeding, and their uterus may be enlarged due to the glands that are growing in the wall of the uterus. On ultrasound, you'll see asymmetric thickening of the walls of the uterus. You may see cysts. The myometrium may have a mottled appearance, and the endometrial myometrial junction may be indistinct. On 3D inversion, we can bring out the adenomyosis and see exactly where it is inside the uterus. So here we have a very obvious case of adenomyosis. You can see on the clip multiple areas in the myometrium that are echogenic but also have cysts in them. You can see that the endometrial myometrial junction is indistinct in various areas. If you do a 3D ultrasound of this, you can see how irregular the endometrial contour is without pouchings of areas of echogenicity, which represent these endometrial implants. Now, besides looking at the contour of the uterus, we look closely at the endometrium itself. Besides anomalies of the duplication-related anomalies, we look at how the fibroids relate to the endometrium. We look at things inside the endometrium, such as polyps, and we routinely evaluate intrauterine devices. Submucosal fibroids can interfere with fertility, so they are associated with infertility. They can be associated with recurrent miscarriages. They are associated with menorrhagia. Patients tend to have heavy periods, and they may even cause postmenopausal bleeding. So when we have a fibroid, we want to know if it's submucosal. This one is intracavitary. You can see that it's hypoechoic, protruding into the uterine cavity. You can see it here. And on the 3D rendering, we see it's occupied inside the cavity. But this one, we wanted to get a closer look at how much it affected the endometrium. We know there's a central fundal fibroid here. We know that the endometrium is difficult to see because of it. With our 3D rendering, we can see that this fibroid is submucosal right along the lining of the endometrium here, and therefore likely to cause problems, including menorrhagia or lead to problems with fertility. Endometrial polyps can make it difficult for a woman to implant the pregnancy, so they're associated with infertility. They can cause bleeding, so patients present with menorrhagia or even postmenopausal bleeding. And in some rare cases, they may be malignant or a sign of endometrial cancer. So here we have a patient on the sagittal view of the uterus. We see there's an echogenic mass inside the cavity. On the sweep, we see the echogenic mass has a few small cystic spaces. And here's the 3D rendering showing that endometrial polyp inside the uterine cavity. This patient had an endometrium that was difficult to evaluate. We weren't sure what was going on here. There were cystic spaces. We weren't sure where the margins were. Putting on the color Doppler, we saw flow in all of this area. So we did a 3D, and on 3D reconstruction, you can see the sides of the endometrial cavity, and then you can see this mass protruding out of the superior portion of the endometrium and expanding it. This was an invasive endometrial cancer that had grown out of the endometrial cavity. When doing sonohysterography, we can assess the contour of the uterus and of the endometrium, but we also can look for polyps and other things that we might not see without putting saline into the uterine cavity. With 3D, we can inject the saline and then take a full sweep, so we don't have to rush around to capture the distended cavity before the saline slips out. This is makes for better imaging and minimizes the time and the amount of saline that's required. So here we have 3D rendering of a patient prior to her sonohystogram. There's a normal endometrial cavity. The balloon has now been placed inside the cavity, and this will now be distended with fluid. And on the 3D, we can see just on this one rendering, a smooth contour to the endometrial cavity. But we can turn this in any way we want to look at all parts of the cavity without having to inject this patient again. And here's a patient who had a suspected polyp on the ultrasound. Once fluid was instilled into the cavity, we can see that fluid surrounds this polyp. This is the balloon below the polyp. And here's the 3D rendering showing the outer contour of the polyp outlined by fluid inside the uterine cavity. We find 3D invaluable for the assessment of IUDs and to also look at tubal occlusion devices. It's particularly good for IUDs. We always take a 3D view of the uterus that has an IUD. Here you can see a T-shaped IUD sitting nicely inside the uterine cavity. This is a normally placed IUD. You can even see the string sliding down into the cervix. So this patient had a lost string, so she was sent for her IUD evaluation, and initially it was thought that, oh good, the IUD's in good spot. But then when we looked a little further, we wanted to see what happened to the string. And sure enough, when we looked closely, we were able to get a 3D rendering of the string inside the cavity. So it had been pulled up and is sitting here with the IUD. So the IUD is in good position, but the string has been retracted into the cavity. When an IUD is malpositioned, it is more likely to cause pelvic symptoms than when the IUD is in normal position. In fact, it's twice as likely to cause symptoms either of pain or abnormal bleeding than if the IUD is properly placed. So sometimes patients with IUDs are sent because of pain and because of abnormal bleeding to assess the position of the IUD. So here's a patient who has an IUD who, on first glance, you might think the IUD is in good position because it's T-shaped and across the top of the uterus. But this IUD, it's the ends of each of the limbs has penetrated the wall of the endometrium into the myometrium here and here. And when this happens, this causes pain for the patient. So this is embedded despite the fact that it's maintained its correct orientation. But we've seen them in all kinds of positions. Here we've done a 3D acquisition, and we see on the reconstruction that the IUD is upside down. The stem that should be pointing towards the cervix is up at the right fundus, and the limbs are in the lower uterine segment. And here's a slightly closer look, and I expect that's a piece of one of the string because that will get pulled up with the bottom of the stem. And here's another one. This patient presented with pain with a known IUD in place. It was very difficult to tell if the IUD was properly placed on the ultrasound despite two cine clips through it. But on the 3D rendering, we can see that the stem of the IUD is low in the uterus, that one limb is penetrated all the way into the myometrium on one side and the other a little bit on the other side. And this one is completely flipped over and pulled the string up with it. We can see the string traveling up to the top of the uterus with the stem upside down and the limbs at the bottom in the lower uterine segment. So we'll move on now and talk about obstetrical ultrasound and its uses, how we use 3D ultrasound. So we use it initially for early pregnancies to look at the implantation site. And sometimes that's very important because it may be difficult to distinguish an interstitial ectopic pregnancy from a pregnancy that's normal intrauterine but eccentrically located. We also want to assess pregnancies when there's a duplication anomaly and look at cervical ectopic pregnancies, and we can look at cesarean scar implantations. So here's a normal early intrauterine gestation. On our 3D rendering, we see the pregnancy and the early embryo inside the uterine cavity. Almost no early implantations are right in the middle of the uterus, because as you recall, the early implant, the blastocyst, when it comes to the uterus, has to embed itself on one side of the uterine cavity or the other. So they're virtually never right in the middle, and this may not be in the middle, it may be closer to the front or closer to the back. So it's pretty unusual to get one where the pregnancy is right smack in the middle. So they're often eccentric, but when they're very eccentric, it can be concerning because you may worry that you're looking at an interstitial ectopic pregnancy. You remember that the interstitial portion of the fallopian tube is that portion of the fallopian tube that travels from the endometrium to the fallopian tube outside the uterus. So it travels through the myometrium to get there. That's called the interstitial portion. So this is a transabdominal scan on a patient who had a very early IUP, very high up in the uterus, off to one side. It was very concerning that this might be an interstitial ectopic pregnancy. Here you can see on transvaginal, again, you can see this pregnancy way off to the side, and it was initially thought to be an interstitial ectopic pregnancy, but a discussion in my group, we always go over cases together. We're saying, I don't know, it could be normal, could be okay, bring her back. We'll do a 3D. So we brought her back and we did a 3D ultrasound and we did some reconstruction, as you can see here. And if you look closely, you can see that the endometrium communicates with this gestational sac. Here's a closer look now with a good reconstruction showing that the endometrial cavity does communicate with this sac. And so this is an eccentrically placed normal intrauterine pregnancy, not an interstitial ectopic pregnancy. And just for proof of that, here we see that pregnancy 4 months later with a profile of the normal growing fetus. What about this one? Another eccentrically placed pregnancy. The pregnancy is actually over here. You can see the yolk sac on the clip, and there was free fluid over on the other side. So what's going on here? Well, with our 3D reconstruction, we can see what's going on. This patient had a T-shaped uterus, and the implantation was up at the right fundus, but normally implanted in the endometrium, which is attached directly to this pregnancy. Now compare that to this one. Here we have an interstitial ectopic pregnancy. We see on sagittal view, there's no pregnancy in the uterine cavity. And we see a pregnancy that's protruding off of the uterus here. It's moving with the uterus, so it's not separate from it, like you might see with a tubal ectopic pregnancy. You can see a heartbeat in here. I also want to point something else out to you. All these little black spaces, these are what an early placenta accreta looks like. We only see those in abnormal implantations, such as cervical ectopic pregnancies or some cesarean scar implantations. And we see it here with interstitial ectopic pregnancies. So this is a clue that this is attached to myometrium and not endometrium. And here's the 3D for this patient. On the 3D reconstruction, we see a normal endometrial cavity. We see some myometrium separating the cavity from this protruding interstitial ectopic pregnancy. And this is just another reformation of the same thing, showing that ectopic pregnancy. What about this one? There seem to be 2 endometrial cavities, and there are, because this is a septate uterus. So if we scan through and acquire 3D volume, we can see the septum showing that the pregnancy is in the right side of the septum and the other cavity on the left. These patients are more likely to have bleeding than patients with normal uteruses because the horn or the side that doesn't have the pregnancy thinks it should, and therefore may start bleeding because it doesn't have a pregnancy attached to it. And yet it gets all the blood supply thinking it is pregnant. What about this one? We thought this one also might be a septate uterus on our sagittal views, but when we did a 3D reconstruction, we discovered that she had a uterine synechia or scar that protruded into the cavity, and she has a normal shaped cavity. We use a 3D ultrasound to evaluate fetal anomalies, but not to detect them. Once we find a fetal anomaly, the 3D may provide us with more information to help us assess the anomaly. We can use it for the face, for central nervous system anomalies. For skeletal anomalies, it's very good because we can make bony windows. For hands and feet, it's terrific because we can see the positioning of the hands and feet and even the fingers and the toes. And we look at it for ventral wall defects and the external genitalia. This is a fetus, unfortunately, has anencephaly. This is when the cranium and brain fail to develop or develop in an abnormal way and then regress. So we're left with a lower face without a forehead. We have no brain behind the face and no cranium behind the face. And here we have the 3D rendering showing the top of the skull open to the amniotic space. This is the ear, this is the eye, nose, mouth, and chin. This is a fetus who has a vein of Galen malformation. I'm showing you this to show what we can do with our color and 3D imaging. You can see the tangle of the arterial venous malformation and then the large vein of Galen draining back to the sinuses behind. And you can see we can also spin it to look at it just like they do with other imaging modalities. Vein of Galen malformations are malformations that can have a lot of flow in them. And here we see lots of turbulent flow. And they may have so much flow that they may cause some cardiac failure in the fetus and hydrops. Interestingly, vein of Galen malformations are rarely detected in the second trimester. So these patients may present with a normal second trimester ultrasound, and then they may be first diagnosed in the third trimester, and they can also be diagnosed later after birth and later in early childhood. Ultrasound 3D is great too for the fetal face. Once we found an abnormality of the face, it's a way to show the parents what the baby will look like at birth and to help the plastic surgeons with reconstruction planning. We can see on the 2D ultrasound of the nose and the lips, we have the nose here and two nostrils and a gap in the upper lip extending up to one nostril. And this is the lower lip. You can see it on the 3D as well. This was a difficult one to detect because it was only a cleft lip, not a cleft palate. And here on the 3D, you can see the defect, which side it's on, and how deformed the nose might be, which in this case was not deformed at all. This fetus has a cleft lip and palate. This is a young fetus of only about 16 weeks. You can see a large cleft on one side extending way back into the palate. And this fetus has a bilateral cleft lip. On the 2D, you can see two defects in the upper lip. Here we can see it here as well. And on the 3D, you can show what it would look like with the two clefts, one up to each nostril and the central portion left in between. This is a fetus who has Naegger acrofacial dysostosis. This is a syndrome that's characterized by severe micrognathia and upper extremity reduction defects. You can see that on a view of the fetal face, there's almost no chin at all here. The ear is low set, and we can see how abnormal the whole arm is, very foreshortened and turned because the radius is hypoplastic. And so this syndrome, we can make the diagnosis by looking at this, and we can show the parents what the baby will look like. I really like 3D for skeletal anomalies. I like the fact that we can make bony windows. I love looking at the fetal spine. We can evaluate meningomyelocele and help determine the levels. We can look at hemivertebrae, and we can look at other bony structures, including the arms and legs, and skeletal dysplasias. So here are a couple normal fetuses. You can see how clearly we can see the spine at every level. We can see the 3 ossification centers that characterize the fetal spine, the central vertebral body, and then the 2 posterior ossification centers. And this is what the fetal spine looks like. And we can also see the ribs coming off on each side. And we can also look at the bones in the extremities. This is a normal fetus and a normal fibula and a normal tibia. So what kinds of things might we use 3D for spinal abnormalities? We can use it for meningomyelocele to assess the level. We can look at hemivertebrae. I've seen diastomatomyelia, so we could look at that to look and see if there's a bony spur or whether it's cartilaginous. We can look at caudal regression or sacral agenesis and other things such as sacrococcygeal teratomas. So here's a baby with a meningomyelocele. We have a transverse view of the lower spine here, and we can see splaying of the posterior elements here. And we see protrusion of a cystic structure, which is called the dorsal sac of the meningomyelocele. On our 3D rendering, we can see that the interosseous, the space between the posterior elements is normal to about L1, and then starts to splay at L2 and is widely splayed at 3, 4, 5, and into the sacrum. So this is an extensive lumbosacral meningomyelocele. Hemivertebrae in and of themselves don't cause any serious problems, but because they are associated with a variety of symptoms, when we detect syndromes, when we detect them, we need to look carefully for the other findings with such syndromes. On ultrasound, we may see a kink in the spine and a mismatch of the posterior ossification centers. So here is a fetus with hemivertebrae. You can see that on the first lumbar vertebra, we have 1 posterior ossification center on one side and 2 on the other side. Here's a slightly different view, and here's a magnified view. I showed this once at a conference with somebody who I highly respect, who's really, really smart. And he came running up to me after the meeting and he said, "Go back to that slide, go back to the slide." He says, "Count the ribs." I said, "Count the ribs? Okay, fine, I'll go count the ribs." So you can count the ribs, and sure enough, there were 13 ribs. Now, I already respected this person very much, and I was very impressed. He saw this from the back of the room. I don't know how, but it's because it is associated with hemivertebrae, but this baby had 13 ribs. This mom came for evaluation of her fetus for a fetal survey, and the spine was unevaluable because of the fetal position. She came back 2 weeks later, and the spine was still unevaluable for fetal because of fetal position. She came back a 3rd time, and she got me. And I tried and tried and tried, and I said, "I'm having a really hard time." I just knew it couldn't be right. So I sent her to her OB appointment, and I said, "Come back after your appointment and we'll try again. I don't want you to have to come back to the hospital." So she came, and at that point I had a better view of the fetal spine and chest. And I saw that there were multiple segmentation anomalies in the upper spine, and that the ribs were very abnormal, very elongated and stretched out. Now, I'm sure that's not what she wanted to hear from me. I'm sure she just wanted to hear she had a stubborn fetus who wouldn't turn over for anybody. But unfortunately, I did find this. And here you can see at birth what that chest looks like. I think it's a pretty good rendering considering this was only at about 20 weeks gestation, and this is now the x-ray after birth. Here you can see those elongated ribs and the confused mess of the segmentation anomalies in the middle of the thoracic spine. Sacral agenesis, like caudal regression, is a complication associated with fetuses of diabetic mothers who have poor glucose control in the first trimester. It leads to hypoplasia or absence of 2 or more sacral vertebrae, and also to pelvic and sometimes lower extremities, extremity anomalies. So here's a fetus where the spine was too short. We were scanning. The spine seemed too short. So we did a 3D rendering of the lower spine. You can see that the This is the bottom thoracic vertebra because it has a rib on each side. So we have lumbar vertebra 1, 2, 3, and lumbar vertebrae 4 is triangular shaped, wedged in between the iliac crests. So this is a fetus who is missing the entire sacrum as well as the lowest lumbar vertebra. And here it is at birth. I would say we did a pretty good rendering in utero and got it just right with that triangular shaped 5th lumbar vertebra. Notice how small the pelvis is, very, very small. And that is unfortunately one of the things that happens with these fetuses, that the structures, especially the bony ones below, don't develop appropriately. These skeletal windows are great for evaluating skeletal dysplasias. They're also good for surface rendering to see what the external appearance of the fetus will look like after birth. This fetus has osteogenesis imperfecta type 2, and you can see we have here a view of the fetal head, which is very large compared to this very small upper extremity. This is the humerus, very small. The radius and ulna are markedly curved with the hand here under the chin. This is a magnified view of the other upper extremity showing marked curvature of the humerus and the radius and ulna next to each other, very short. This fetus has arthrogryposis. With the 3D, we can show the very abnormal positioning of this fetus due to the multiple joint contractures and inability to move. You can see that the hand has abnormal posture. The foot is rocker bottom. And here we can see the whole fetus with its hands up by the face and the legs in a very abnormal position, almost like the knees are inverted and the hips were persistently flexed so much. And the baby has a lot of difficulty moving because of the arthrogryposis. Here's another fetus who had arthrogryposis involving primarily just the hands and the feet. So during all the ultrasound exams, the hands were persistently in this abnormal configuration, and the foot was consistently pointed like this. It never could flex. It was hyperextended the whole time. And here you can see after birth that we did a pretty good rendering of what that was going to look like. We look at the hands and the forearms to look for abnormalities. Abnormalities, particularly of the radial ray and the thumb, are associated with syndromes, and therefore it's important to evaluate for those which may be our hint to a syndrome, but also when we find something that might be a syndrome, to look at the forearms and the hands. So here's a fetus with a very abnormal thumb. You can see that that thumb is not attached properly to the hand. Here we can see it here magnified. There's also some curving of the forearm. When we turn on the bony window for this, we can see that there's foreshortening of the radius. It's too short, it's hypoplastic, and that's why this hand is turned inward due to the hypoplastic radius. We can also see that one of the metacarpals is missing, which is why the thumb is precariously attached to the rest of the hand. And this was a fetus who proved to have the Vauctrel syndrome. Here's a fetus with very abnormal positioning of the hands persistently, and this was a fetus with trisomy 18. Trisomy 18 fetuses are characterized by abnormal positioning of the hands themselves, but also abnormal positioning of the fingers, so they have persistently clenched fists. So what you'll see with a trisomy 18 fetus is overlapping digits, overlapping in a way that would be hard for you to hold that posture for a long time. So you can see that the index finger overlaps the middle finger and the little finger overlaps the ring finger. So they overlap in a way that's very hard to hold, but that's how this baby's hand is all the time. And they very often cannot even open the hand. So the hand remains clenched in this abnormal position. This is just a cute picture of polydactyly. You can see that there are 6 toes. You can see 6 toes across here. And here you can see that there is a 6th finger as well. Polydactyly can be associated with syndromes. So there again, you want to look at the rest of the fetus and see if there's anything, but it also can be hereditary. So if the patient has a family history of polydactyly, then you can reassure the patient that it's likely just hereditary polydactyly, and everything else, if it looks fine, will probably be fine. This is a 13-week scan where some fingers were missing. You can see here that the hand looks abnormal, and we've done some 3D renderings to show that there's a thumb and there are only 2 or 3 fingers. I think there were 3. So we have a thumb and a couple here, and then a thumb and a truncated finger, and then a normal finger. So we really can, even at 13 weeks gestation, see these things with our ability to reformat the acquisition. This fetus is missing a hand. We certainly were able to identify that on the 2D ultrasound when we saw the ulna and the radius and no hand. And on the 3D, we can show the parents what that upper extremity will look like. But we can also help the surgeons by showing them whether there are any carpal bones to see if they have a wrist to work with. So these are bony reconstructions of that fetus, showing that there are several carpal bones here, several carpal bones. They're not all there, and there are no fingers or metacarpals, but certainly there can be a wrist of some form. And I have to say that they're amazing at what they can do with these children. Like the hands and the upper extremities, the lower extremities are also very important for finding anomalies isolated to the lower extremities, but also for being a clue to other abnormalities in the fetus. I've seen proximal focal femoral deficiency. We can see club feet, rocker bottom feet. Amniotic bands can disrupt any of the extremities. And I've seen the sandal gap deformity, which can be associated with trisomy 21 and cardiac defects. So here's a fetus with a club foot. This is the 3D superficial rendering showing what that foot will look like after birth. And this is the bony window. So on the 3D rendering, you can see that the baby to walk would have to walk on the side of the foot. And on the bony window, we can see that the bones of the foot sit in parallel for the bones of the lower extremity, which is the classic description of this on ultrasound. So instead of this being perpendicular, so you'd only see one next to each other, we have all the bones of the foot in the same plane as the tibia and fibula. And this fetus has a rocker bottom foot. It certainly looked abnormal on the 2D ultrasound, but with 3D reconstruction, we saw the classic finding of rocker bottom, which is protrusion of the heel, absence of an arch, but rather convexity to the bottom of the foot, and upward turning toes. This is associated primarily with trisomy 18, but may be seen with some skeletal dysplasias and some arthrogryposis cases. We can use 3D to look at abdominal wall defects, to assess the size and contour, and show what the baby will look like after birth. Here's a baby admiring its normal cord insertion, looking down to see the cord coming out of its umbilicus in a normal fashion. Here is an 11-week fetus looking down at its cord and trying to figure out what's going on. But I'm sure you all recognize that this is normal physiologic herniation that we see at 11 weeks gestation. It's at the base of the cord. This is a normal finding prior to 12 weeks gestation. But after 12 weeks, we should not see anything in front of the fetal abdomen coming out of the fetal abdomen. This is an omphalocele. You can see on the 2D ultrasound, we have the spine back here, and we have a large mass protruding from the anterior abdominal wall. It's taken so much of abdominal contents with it. It has the stomach and bowel and probably some of the liver, more than what you see at the abdomen at that level. So this is quite a large one. And here are 2 different 3D renderings showing how big this is compared to the size of the fetus. Quite a large one. Compare that to the appearance of a gastroschisis, where instead of that nice rounded smooth contour that we see with an omphalocele, we have a lobular irregular contour of the structures that have herniated through the defect in the abdominal wall. This is gastroschisis. And when we do the 3D rendering, it's clearly a matted loops of bowel herniated outside the fetal abdomen. A double bubble is easy to diagnose. It is associated with trisomy 21 because it indicates duodenal atresia, but we can make some pretty pictures. Here is a fetus with duodenal atresia. On the 2D ultrasound, you can see the dilated stomach. This is the pylorus, and here's the dilated proximal proximal duodenum. This is the gallbladder next to it. We can do a 3D rendering and then just look at the fluid inside the baby's abdomen. And here we see our dilated stomach, markedly dilated duodenal bulb with the gallbladder sitting on top of it. I like the inversion mode for looking at obstructive uropathies, hydronephrosis, hydroureter, posterior urethral valves, big dilated bladder. And here we have a ureteropelvic junction obstruction in a single kidney in the fetus. The other kidney was normal. We can take this kidney and render the outline of the collecting system, see the dilated pelvis and the dilated central and peripheral calyces. And posterior urethral valves, I showed you at the beginning, a bladder outlet obstruction with posterior urethral valves, a big bladder. These babies also get hydronephrosis and hydroureter. This is one of the biggest bladders I ever saw. I took a 3D rendering of it. You can see a very big bladder with a protuberance of the dilated posterior urethra. And then when I turned it around, I was able to see the big, markedly tortuous ureter leading up to the hydronephrotic dilated kidney. So these are really fun and do help you see things that seem to be hidden behind all these things like these huge bladders. But the other thing that's so great about 3D ultrasound in obstetrics is the enjoyment and satisfaction we give to our patients. We can show them a little 9-week fetus moving around inside like we see here. We can say, we're watching you. We can show them things like this. So I hope that this has been interesting to you. I haven't put you to sleep or frustrated you. And now this baby's telling me to stop. I thank you very much for your attention today, as well as earlier this morning during our board review. Thank you for inviting me.
Carol, thank you so much. That was really, really terrific. And everybody can see why you're such a great physician, because you enjoy what you do so much and you care so much about the patient. So really, on many, many levels, very, very inspiring. We have a little bit of time for questions, and you can ask a question either by raising your hand, in which case G2 or Angel will unmute you, or you can type your question in the Q&A in the Zoom webinar or in the chat, and I will try and read those so that Carol won't have to be bothered looking for them.
I did see one already, which was, are there any energy concerns about using 3D in early ultrasound, in early pregnancy? Actually, the answer is no. The sweep that's used for 3D ultrasound is identical to the sweep that we use for 2D ultrasound. It doesn't introduce any more energy than otherwise, and it's just accumulating a sweep. So it does not add energy like Doppler would, either color or spectral Doppler.
Does it, how does it affect the time of the exam? Does it reduce the number of static images you have to take in your experience, or is this still an add-on kind of situation?
So in our practice, it does reduce the number of static images, but not by a lot. But it significantly improves the ability of the radiologist to interpret the findings. So the radiology satisfaction is much better. You know, when you see something at the edge of a picture and you're not sure what it is, you know, at the edge of an image, if you have a clip through it so you can see it front to back, then you can figure out what it is.
Related to that, somebody did ask how long of a time slot do you allocate for each patient for a GYN ultrasound or a fetal ultrasound with these complex cases, or is, again, it's just an add-on to your schedule?
We do not give extra time for complex cases because you never know ahead of time if they're gonna be. We
Right.
just stick them in. So people have half-hour slots, and you hope there's some quick ones so that you have time to spend the time on the more complicated ones.
And there was one question about language. When you're talking about the eccentric pregnancy, uh, interstitial versus, you know, pregnancy in the horn of a duplicated uh, uterus or something. Do you ever use the term, Carol, any more angular pregnancy that's sort of in that pointed or triangular configuration of the endometrium just as the tube enters through the myometrium?
So I have never used the term, and I don't like the term. I don't like the
Okay.
term because they become normal pregnancies, and all you're doing is stressing out everybody. So I don't like the term and I don't use it.
There was some early literature, Carol, that thought that angular pregnancies, at least what they term them, you know, right up there by that as the tube enters, had a higher incidence of fetal loss. But you think that's not true?
Um, so I don't know whether it's true or not. They may. My concern is any kind of risk to the mother. So I don't. If there's no chance she's going to rupture a uterus,
Hmm.
then I want to give every pregnancy every chance. And I've seen
Right.
pregnancies in so many corners of the uterus that all turn out to be fine that
Hmm.
I'm reluctant to give an assignment to the name of one that I think is going to be a normal pregnancy. That one I showed you that we brought back, they were ready to operate on her.
Oh,
Um,
really? Wow.
yes, and I'm like, wait, that we were
Mhm.
arguing, and
Right.
so we brought her back and sorted it out.
Well, we've used the term here, but we usually say specifically it's an IUP and, you know, make sure everybody knows it's an IUP, but maybe it would be a good idea to remove that from our lexicon.
Well, we just don't like to stress out our patients. The
Yeah,
other term we never use is a cornual pregnancy.
right. We don't either. Yeah,
Okay, good.
yeah. Um, that's too confusing. Nobody knows what it means, and it can mean anything to, I mean, a whole variety of different things to different people. So we've just dropped that.
Great, us
Um,
too.
yeah. So another question: who does your 3D reconstructions? A radiologist at the device, or have you trained your sonographers to do post-process imaging?
The sonographers do the post-processing imaging right on the machine itself. It's actually easiest and quickest on the machine. And so they take a sweep very quickly, line it up, and take a single picture of the whole of the coronal view of the uterus, for example, and store it in a volume form so that in some cases we'll go back in and pull it up again on the machine and take it. But in most cases, they do a good job. And one of the reasons we want them to do it in the room is to make sure the acquisition was adequate. Because of the orientation of the uterus, you may not get a really good sweep and you may have to switch how you acquire it.
Hmm. What's the learning curve for a sonographer to get adept at doing this, do you think?
Oh,
Uh,
that's a very difficult question. It's highly variable depending on
mhm,
the sonographer and how well they learn anything. So,
mhm.
and also how often they're exposed to it to get to try. This is why we do 3D though on every single GYN, because very quickly all of our sonographers, including our students, are really good at it.
Right, we try and do that as well. I think I learned that from you on a prior lecture.
Sounds good.
Any other questions from anybody? Well, if not, Carol, really, this was absolutely fabulous. And thank you so much for your board review and being our inaugural virtual Grand Rounds presenter. This really was terrific and will be really helpful to all of us. And enjoy 2021.
Yes,
Looking
thank you.
forward to a good year.
I'm honored to be your first speaker. Thank you.
Again, thank you so much.
Okay.
All right, take good care. Thanks,
Yeah, you
everybody.
too.